Hi guys, welcome back to the Reed Harrison series. So in the previous class on the Reed Harrison series, we have learnt about the thyroid physiology. So we have a fair idea about how the thyroid gland works and how is it regulating various body functions. So today we will start learning about the diseases of thyroid function. So first we will start with hypothyroidism, and in the eventual classes we will study about hyperthyroidism as well. Okay. So now, when we talk about hypothyroidism, that means there is decreased production of thyroid hormone, that is T3 and T4 production is reduced. So we will begin by first understanding the causes. Then we will try to understand the clinical features, diagnosis and management. Now causes, there are various ways to remember it. I have a simple mnemonic for us to remember the causes for hypothyroidism. The mnemonic goes like this: Harris MD. You can think of someone called Dr. Harris who has done MD. Okay. So where H stands for hormone resistance. H stands for hormone resistance. So there are conditions where the thyroid receptors are dysfunctional. So even when the thyroid gland produces the hormones in normal quantities, they may not be able to work at the level of receptors. So hormone resistance is one of the cause. Okay. Then A stands for the autoimmune thyroiditis. Autoimmune thyroiditis, and we all know when it comes to autoimmune thyroiditis, the main cause which is known to cause autoimmune thyroiditis is Hashimoto's thyroiditis. So for all practical purpose, whenever I say autoimmune, you should think of either Hashimoto's, which is most common, or you can think of Graves' disease, which is the second most common cause for autoimmune thyroiditis. In case of Graves' disease, we end up with the hyperthyroidism. With Hashimoto's, we end up with hypothyroidism. Okay. Then R stands for, you might have heard about a condition called as Riedel's thyroiditis. Riedel's thyroiditis, which is a form of infiltrative thyroiditis, where there is infiltration of the thyroid gland by IgG4 positive lymphocytes. Okay, so that is Riedel's thyroiditis. Then another R stands for radiation. Radiation therapy, which could be either we are trying to treat the thyroid disease itself by giving radiation to thyroid gland like radioiodine therapy, or it could be radiation given to the neck for other malignant conditions, right? Radiation therapy including radioiodine therapy, which is usually done for the treatment of Graves' disease. Okay. Then I here stands for the iodine deficiency. Iodine deficiency. Then S here stands for the surgical causes or surgery, mainly when we have thyroid tumors or Graves' disease which we are not able to manage medically or with the radioiodine. In such cases we go for the thyroidectomy. So if someone has undergone total thyroidectomy or subtotal thyroidectomy, they may become hypothyroid. Okay. Then M here stands for malignancy. So it could be thyroid cancers as well as the non-thyroid cancers where there is metastasis to the thyroid gland. Okay. Then D here stands for drugs. And as an undergraduate student, one drug that you should not miss to remember when it comes to thyroid gland is amiodarone. Amiodarone is known to cause both hypo as well as hyperthyroidism. It is known to cause hypo as well as hyperthyroidism because this is an iodine containing drug. This drug contains iodine, and this iodine can inhibit the thyroid hormone synthesis with the help of Wolff-Chaikoff effect. So it can cause hypothyroidism as well. By making more iodine available, it can also cause hyperthyroidism. So these are the main causes. So you can remember it with the mnemonic Harris MD. Easy to recreate in the exam. But if you want to become a good doctor, you should know among all the causes that we mentioned, which are more common. So common ones are Hashimoto's thyroiditis, then iodine deficiency, at least in some part of the world, and iatrogenic, that is like post-surgical hypothyroidism. So in the exams, they may ask you an MCQ. What is the overall most common cause for hypothyroidism? Overall, the most common cause for hypothyroidism is not iodine deficiency. It is Hashimoto's thyroiditis or autoimmune thyroiditis. Hashimoto's thyroiditis is the most common cause for hypothyroidism world over. So if you see 10 patients of hypothyroidism, I'm pretty sure more than 9 of them, I said not even 9, more than 9 of them will have mostly Hashimoto's thyroiditis. Remaining 1 cases may be post-surgical, maybe post-radioiodine therapy, or maybe drug-induced, or all other causes that we spoke about. But if in an exam they ask a very specific question, what is the most common cause for the hypothyroidism in iodine deficient population, then only you should mention iodine deficiency. There was time in the past where iodine deficiency was the leading cause for hypothyroidism, but not anymore, because most of the countries have adapted the iodization of the salt. So now you are getting iodized salt. So with that, iodine deficiency is almost eliminated. But for the sake of exams, you should remember that iodine deficiency is mainly more common in mountainous regions. Mountainous regions. In India, by default, the table salt is iodized. So whatever salt you are getting commercially packaged is iodized. So we are not having iodine deficiency as a major concern anymore in India. Okay. Now that we are aware of what causes hypothyroidism, let us try to understand what clinical features these patients present with. And we will be able to understand the clinical features only when we have a fair idea about pathophysiology. Like if body is not producing sufficient T3, T4, what all consequences I can expect. Now here, when we talk about hypothyroidism, I have already told you in the previous class also, when we talk about hypothyroidism, we classify them as primary and secondary hypothyroidism and tertiary, right? So where is the problem in the primary? The problem in the primary hypothyroidism is in the thyroid gland itself. The main gland which is supposed to produce the final hormone, if that is dysfunctional, वो ठीक से काम नहीं कर रहा है, then we call it as primary. And उसके ऊपर का जो first level regulation है वो काम नहीं कर रहा है, तो we call it as secondary. So first level regulation is pituitary and higher level regulation is hypothalamus. तो यहाँ पे hypothalamus है, and as we know hypothalamus produces TRH, and this TRH stimulates the pituitary gland to produce TSH. तो pituitary gland produce करता है TSH, and this TSH stimulates the thyroid gland acting through the TSH receptors to produce what we call as T3 and T4. Now, if the problem is at the level of thyroid gland, we call it as primary hypothyroidism. अगर problem pituitary के level पे है, तो we call it as secondary, and if the problem is at the hypothalamus level, we call it as tertiary. Now, the causes that we listed, tell me what all are majorly primary. Majority of the causes are primary. Like autoimmune, Hashimoto's thyroiditis, which gland is affected? Thyroid gland itself. तो ये primary हुआ. Reader's thyroiditis, pathology कहाँ पे है? Thyroid level पे, तो this is also primary. When I give radiation, which gland is getting affected? Thyroid gland. So this is also primary. Iodine deficiency, which gland is not able to work? Thyroid gland. TSH production does not require iodine. So ये भी primary हुआ. Surgery, what am I taking off? The thyroid gland. So this is also primary. Drugs, they are interfering with the thyroid gland itself. Right, malignancy, I am primarily talking about thyroid malignancy. So majority of the causes are primary. Secondary मतलब क्या हो सकता है? या तो I have done the surgery of the pituitary. I had some, let us say, prolactinoma or something. To remove that, I have removed the pituitary. While removing the pituitary, TSH producing cells are also removed. या तो pituitary में एक tumor है, एक non-functional pituitary adenoma है, which is compressing the TSH producing cells. That's why it is not producing TSH. Those conditions can happen, but they're quite rare. So primary is the most common cause. So we will concentrate on the pathophysiology of primary hypothyroidism. So primary hypothyroidism में क्या होता है? T3 T4 production is low. Now we already know that T3 T4 is required for maintaining the basal metabolic rate. जैसे ही T3 T4 कम होगा, there is decrease in the basal metabolic rate. The rate at which body can burn calories is reduced. And second thing is, we have learned while learning the thyroid physiology that the thyroid hormone T3 T4 influence the expression of the adrenergic receptors. So there will be down regulation of the adrenergic receptors. So if I'm talking about primary, एक और change हो सकता है. Something should happen to TSH. So TSH के साथ क्या होगा? If it is primary hypothyroidism, like problem क्या है? Primary में है. So if the problem is in thyroid gland itself, it is not producing sufficient T3 and T4. So T3 T4 तो down हो गया. And as we know that this T3 T4 will have a negative feedback on TSH production and the TRH production, right? It will have a negative feedback. तो ये feedback क्या होगा अब? Feedback is gone. So once T3 T4 decreases, what should happen to TSH and TRH? Once the T3 T4 decrease, TSH क्या होना चाहिए? Of course, it is going to go up. It will start increasing. So in primary hypothyroidism, TSH will be decreased. TSH will be decreased. Clear? Okay. Now what consequences? Sorry, the TSH will be increased to compensate or to stimulate the thyroid gland to produce more T3 T4. So now what consequences this will lead to? Decreased BMR. इसके वजह से क्या होता है? The rate at which we burn calories is reduced. So हम कम calories burn कर रहे हैं तो body के साथ weight का साथ क्या होगा? The weight will start increasing, right? So these patients will have weight gain, which is one of the very common complaints that these patients come to hospital with. Okay. Now basal metabolic rate plays a very important role in regulating the body temperature, because जो temperature है, heat है, कहाँ से आएगा? From where it will come? By burning the calories. So if I'm burning slow, I'm producing less heat, and if I'm producing less heat, maintaining body temperature becomes difficult. So these patients will now have what we call as cold intolerance. Cold intolerance. So whenever I get exposed to cold, like okay, atmosphere is very cold, body wants to maintain the body temperature in the physiological range. So how will I maintain it? By increasing the heat production. Increasing heat production के लिए क्या चाहिए? Burning the glucose. But that process is slowed down. तो मैं compensate ठीक से नहीं कर पाऊंगा. So I can end up with cold intolerance. Cold intolerance. And अगर basal metabolic rate कम है, so my ability to be able to athletic will come down. क्योंकि if I have to be athletic, I have to burn glucose quickly, right, to make those ATPs available. But that's not going to be fast here. So I end up with fatigue. I will be quite tired all through the day. So this decreased BMR can lead to weight gain, cold intolerance and fatigue. दूसरा क्या है? There is decreased adrenergic receptors. Means receptor density जो beta receptor से वो कम हुआ है. So if thyroid hormone increases, the adrenergic receptors increase. So they stimulate the cells so that like sympathetic activity will be increased when thyroid hormone is high. यहाँ पे sympathetic activity will be decreased. So that results in bradycardia, heart rate इनका कम होने लगेगा. So these patients can have bradycardia. Okay. What other symptoms we can develop because of decreased sympathetic activity? So decreased adrenergic receptors is equal to decreased sympathetic activity. So this can also contribute to development of constipation. Okay. Now on the other hand, इस तरफ भी देखते हैं TSH. TSH has increased. अगर आपको लगता है कि TSH is supposed to only stimulate the production of the T3 T4, we are wrong. TSH is known to stimulate one more factor. What is it? TSH stimulates. This will stimulate fibroblasts. And when we stimulate fibroblasts, what fibroblasts do? They will increase production of mucopolysaccharides, glycosaminoglycans, and hyaluronic acid. And this production of hyaluronic acid, what consequences this can lead to? All these substances, they get deposited in tissues, and when they get deposited in tissues, mainly it gets deposited in skin and the body fluids. So when it gets deposited in the skin, it can lead to one coarse skin texture. Second, it can lead to what we call as myxedema. Okay, now myxedema, whenever we talk about it in the bedside, we generally say that there will be non-pitting edema. Why am I getting edema here? So I want you to pay attention to all these substances are important, but particularly hyaluronic acid. आप में से बहुत लोगों ने would have used this as part of cosmetics, right? किसके लिए use करते हैं? For what purpose we use hyaluronic acid in cosmetics? There are creams, lotions and injections. Lot of celebrities inject hyaluronic acid. Sutapa Samantha, coarse skin refers to scaly rough skin. जो स्मूथ टेक्सचर है वो नहीं रहेगा. Hyaluronic acid is used as a filler. Why is it used as a filler? Like with aging, no, skin starts sagging, there is emptiness created in the facial spaces. तो वहाँ पे वो fillers use करते हैं as hyaluronic acid. Hyaluronic acid inject करते हैं to make you look young. But how does that work? Hyaluronic acid is a hygroscopic substance. Means what? One molecule of hyaluronic acid is capable of binding. It can bind to 200 molecules of water. मतलब अगर एक molecule of hyaluronic acid में inject करूंगा, it will bind 200 molecules of water. तो उस space में क्या होगा? It will fill, it will swell. So wherever I inject, it holds water and swells. तो cosmetics में भी क्यों use करते हैं? So when you apply a layer of hyaluronic acid, it holds moisture, swells, gives that like appearance of hydration. And because it can hold a lot of water, we can use it as a filler. Okay. So if that gets deposited in the skin and subcutaneous space, it will hold lot of water. It will result in edema. So that edema we call it as myxedema, and this is non-pitting. Non-pitting का मतलब क्या है? If you compress that place and hold it for, let us say, 20-30 seconds, if the edema is because of water, there is collection of water, if I compress, I will displace that water and I will create a pit. But यहाँ पे वो pit नहीं create होगा. Why the pit is not created? It's because when there is collection of fluid and when I compress, वो fluid वहाँ से displace हो जाता है. The fluid gets displaced from the space. Like when you have this regular case of edema that you see in heart failure, chronic kidney failure, or liver diseases, anemia, hypoalbuminemia and all, you have edema which is pitting. You compress, fluid is there, it gets displaced, creates a pit. But here, this water cannot be displaced because it is bound to hyaluronic acid, and hyaluronic acid is bound to tissues. So hyaluronic acid displaced नहीं हो सकता है, तो water that is bound to hyaluronic acid also cannot be displaced. So that's why we will not be able to create a pit. This is more common in the pretibial region. So we can also call it as a pretibial myxedema or shin myxedema. Okay. Similarly, the deposition of these hyaluronic acid and all on the face, right, can give rise to coarse faces or a little rounded face. It can give rise to coarse faces, or you can simply call it as facial puffiness. Facial puffiness. So roughly speaking, what is the major change that is happening when we have primary hypothyroidism? दो change हो रहे हैं, एक T3 T4 कम हो रहा है, so there is down regulation of sympathetic activity and decreased BMR, and दूसरा increased TSH is contributing to the deposition of hyaluronic acid, mucopolysaccharides and glycosaminoglycans in the tissues, which will lead to various consequences. As it is added water, there is chance of puffiness of face. So Tapa Samantha, yes, hypothyroidism or puffiness of face is coming because of this deposition of these substances. हम इन्हीं सब्सटेंस को थेरेपेटिकली यूज कर सकते हैं. हाइलुरोनिक एसिड जहाँ पे चाहिए, जितना चाहिए, बस उतना ही इंजेक्ट करेंगे, तो आई कैन ऑल्सो रिकॉन्टूर द फेस. समवन हु हैज लॉस्ट ऑल द फेशियल फैट, वहाँ पे मैं हाइलुरोनिक एसिड इंजेक्ट करके आई कैन ऑल्सो मेक देम लुक गुड. यहाँ पे जरूरी नहीं है, जरूरत से ज़्यादा डिपॉजिट होकर इट गिव्स अ पेक्यूलियर हाइपोथायरॉइड फेस अपीयरेंस. Okay. Now, let us understand the clinical features by looking at the systems. Roughly, we have understood what are the major changes happening. We will reiterate these changes when we go through the systems, right? Now, if the examiner asks you what is the most common presenting complaint of a patient with hypothyroidism, what do you think brings them to the hospital among all the changes we mentioned? Will someone come and say that I have bradycardia? No, right? Will someone come and say, yeah, constipation can bring them to the hospital? Will someone come and say that, okay, I have skin changes? Maybe they can come, but majority of your hypothyroid patients are going to come because of the symptoms related to decreased BMR. So they come to you because they are gaining weight. They come to you because they are feeling fatigued or tired, right? So most common presenting complaint of hypothyroid patients is going to be weight gain and fatigue. Weight gain and fatigue. This is what brings them to the hospital. As doctor, when we question and get more history and examine, we will start seeing other findings. So in terms of skin manifestations, dermatological manifestations, so they can have dry scaly skin, which we call it as coarse skin in simple words. Okay. Second dermatological manifestation is pretibial myxedema, that is non-pitting edema over the shin region. This is mainly because of what? Deposition of hyaluronic acid, glycosaminoglycans and other mucopolysaccharides. As a cosmetic injection, hyaluronic acid does not have a major side effect, but then when not done properly, especially nowadays, no, it's not only done by dermatologists. A lot of unqualified so-called aesthetic doctors are also doing it, and you can see a lot of messed faces. I don't have to take the names, but there are a lot of filler queens, kings available on the social media where you see how their pouted lips and the face is disfigured. But when done rightly, under trained hands, it gives good results. There are a lot of people whose beauty has been enhanced. Okay. But yeah, it's a naturally occurring substance. All of our tissues have some amount of hyaluronic acid. Yahan pe there is increased production. Okay. Pretibial myxedema. Then these people often have hair loss. Patients with hypothyroidism have hair loss. You may be asking why hair loss? Because there is decreased metabolic rate. So जब metabolic rate कम होगा, so जो energy ATPs available हैं tissues को, it will come down. And hair follicles being one rapidly growing cell, right? They're continuously, like hair is growing, it gets affected, its growth gets affected, and we can have hair loss. And this hair loss also leads to a peculiar sign in hypothyroidism. Peculiar sign. And I will call this sign as Hartoghe sign. Hartoghe, or also called as Queen Anne sign. Queen Anne sign. तो इसमें होता क्या है? Hair loss is happening, like you are losing the scalp hair, but in addition to that, you mainly lose lateral 1/3 of your eyebrows. You might see this in a lot of hypothyroid patients. Their eyebrows are thinned and lateral 1/3 is almost non-visible. So that loss of lateral 1/3 of the eyebrows, we call it as Queen Anne sign or Hartoghe. तो यहाँ पे जो lateral 1/3 है, that will be lost. So this we call as Queen Anne sign or Hartoghe sign. So what does it refer to? Loss of lateral 1/3 of eyebrows. So in hypothyroidism, there are a lot of named signs which are often asked in bedside discussion, as well as MCQ based and image based questions. So एक image based question हो सकता है where they will give you a story that a patient presented with weight gain and fatigue, and then there is a photo, and in the photograph you can see that the eyebrows are thinned laterally, or lateral part of the eyebrows is not visible, and then they will ask you what sign it is or in what condition it is seen. Seen in hypothyroidism, called as Hartoghe sign or Queen Anne sign. Lateral 1/3 of eyebrows are lost. Okay. Then coming to the central nervous system manifestations of hypothyroidism. Thyroid hormone decides how actively the neurons in the brain can work, because basal metabolic rate वहाँ पे भी influence करेगा. So if basal metabolic rate is low, neuronal activity comes down, right? So that decreased neuronal activity, when it is very severe, can lead to what we call as Myxedema coma. myxedema, coma, which is a very severe condition associated with very high mortality. Myxedema, coma. Okay. Then second CNS manifestation, it is also called as cretinism. So if before the full development of brain happens and you develop hypothyroidism before the brain is fully developed, then brain may not be able to develop well, resulting in mentally retarded kids. So there is decreased brain function. We will call it as cretinism. So we can have myxedema, coma, which is an emergency, and cretinism is improper development of the brain. So we'll call it as cretinism. In fact, in some of the dialects, using the word cretin is not acceptable because it is considered as हम बोल रहे हैं कि आपका दिमाग ठीक नहीं है. So you can say that, are you a cretin? It is considered as a slang. Okay. Now, will there be impact on the CVS? Yes. CVS has significant impact. What impact it can have on the CVS? Decreased sympathetic activity can lead to bradycardia, and bradycardia can lead to, so as such metabolic rate कम होने की वजह से fatigue हो रहा है. सुधा को समझता सी थायराइड हार्मोन डिसाइड्स योर मेटाबॉलिक रेट, राइट. तो जितना मेटाबॉलिक रेट कम होगा टिश्यूज को ठीक से रेप्लिकेट करना उतना ही मुश्किल होता जाएगा. So when neurons are in a growing stage, if they are not getting sufficient thyroid hormone, so metabolic rate is poor, so neurons will not be able to grow properly. So we'll have an improperly developed brain, and we are going to call it as cretinism. Okay. Now CVS, decreased sympathetic activity, results in bradycardia, and bradycardia results in other consequences. What other consequences? As such, metabolic rate come hai, so we already have fatigue, and when heart rate is less, what is going to happen to your cardiac output? Cardiac output is defined as stroke volume into हार्ट रेट. तो अगर हार्ट रेट कम है तो कार्डियक आउटपुट भी कम होगा. दैट मीन्स द अमाउंट ऑफ ब्लड दैट हार्ट इज पंपिंग आउट इज लेस. तो अगर वो कम है, सो अमाउंट ऑफ ब्लड दैट टिश्यूज आर गोइंग टू गेट इज ऑल्सो गोइंग टू बी लेस. So will I be able to tolerate intense exercise or intense activities? No. So this bradycardia can also result in effort intolerance. So patient may not be able to tolerate effort or exercise, and that can even result in developing episodes of syncope. Heart rate इतना कम हो सकता है कि when I try to do exercise, my brain doesn't get sufficient blood supply. I can lose my consciousness. So we are going to call it as syncope. Okay. Second, ये जो hyaluronic acid mucopolysaccharides that were getting deposited, right? They're not only getting deposited in the skin, they also get deposited in the pericardial space. So if I deposit them, that hyaluronic acid molecules will hold lot of water in the pericardial space, resulting in what we call as pericardial effusion. Or effusion बहुत ज़्यादा है तो it will compress the heart. In that case, we will call it as cardiac tamponade, which can be life-threatening. So it can lead to pericardial effusion. Pericardial effusion. Eventually, when it is too massive, it can lead to what we call as cardiac tamponade. Okay. Now, can it have other endocrine manifestations? Hypothyroidism itself is an endocrine disorder, but it can also affect other endocrine functions. Slowing metabolic rate can worsen your diabetes because you're taking in carbohydrates means sugar. It is going to spike up your blood sugar level. The rate at which your blood sugar is going to be used by tissues is down, so your blood sugar levels will increase. So if the patient is already diabetic, they can have poor control of diabetes if they are already diabetic. Hypothyroidism itself increases the risk of someone developing diabetes because metabolic rate come hai, you are burning less, you become less active, fatigued, you keep gaining weight, you develop insulin resistance, and you end up with type 2 diabetes. So there is poor control of diabetes, there is increased risk of acquiring type 2 diabetes. Okay, and it is also hypothyroidism, Hashimoto's, is associated with type 1 diabetes because ये भी autoimmune disorder है और वो भी autoimmune disorder है, antibodies can affect both conditions. Okay. Then third, very interesting, when we have primary hypothyroidism can lead to hyperprolactinemia. A repeatedly asked MCQ point, ये क्यों हो सकता है? Why hypothyroidism should cause hyperprolactinemia? Why hypothyroidism should cause hyperprolactinemia? The answer lies in TRH. So if I'm having primary hypothyroidism, my T3 and T4 will be less, right? So to compensate, because I'm now losing the negative feedback, TSH will be high. And what will happen to the TRH? Even that negative feedback is lost. So TRH will also be high. The TRH will be high. And this TRH is not only known to stimulate the pituitary gland to produce TSH. TRH also stimulates the pituitary gland to produce prolactin. So if TRH increases, there is increased stimulation of the pituitary gland and we can have hyperprolactinemia. Okay, so therefore I will address the tamponade again. Okay. So we can have hyperprolactinemia. This is because of due to increased TRH in primary hypothyroidism. And when we have hyperprolactinemia, what manifestations we can expect? Hyperprolactinemia can lead to galactorrhea, amenorrhea, and decreased libido or decreased interest in the sexual encounters. So these are all manifestations that we can see with respect to endocrine disease. Okay. Can hypothyroidism affect the musculoskeletal system? Yes. It can affect the musculoskeletal system as well. So here hypothyroidism can lead to what we call as myoedema. What do I mean by myoedema? Edema of the muscle. There are multiple mechanisms, and one of the important mechanism is again deposition of these mucopolysaccharides and hyaluronic acid and glycosaminoglycans. And this myoedema, the muscles are edematous, so they can lead to various manifestations. So myoedema can result in developing cramps. So many patients of hypothyroidism often keep complaining of developing muscle cramps, okay, because the muscle is edematous, it cannot function properly and we end up with cramps. Second, because of the edema, muscle may appear bulky, right? आपने नहीं gym गया है, you are not gone to gym, you are not build the muscle mass, but still it appears bulkier. So that appearance of the bulkiness of the muscles is because of the muscle edema and not because of muscle hypertrophy. So ये strong muscles तो नहीं है, they are weak muscles, but they look bigger, especially the calf muscle. So this bulky muscles of the calf muscles is called as Hoffman's syndrome. It's different from Hoffman's sign. It's called as Hoffman syndrome. So what is this Hoffman syndrome? Bulky calf muscles. These are, right, we can also call it as pseudo hypertrophy. This is called as pseudo hypertrophy because there is no true hypertrophy. Muscle looks bulky because of myoedema, muscle edema. So pseudo hypertrophy of calf muscles is called as Hoffman's syndrome. Okay. One more thing this myoedema can result in. What is that? So when we do this tendon reflexes, right, we give a stimulus to the tendon and what do we expect? The muscle contracts and relax. Like a biceps jerk kar rahe ho, I hit the biceps tendon, the biceps muscle contracts and then relax. That relaxation of an edematous muscle will become slow. So we call it as delayed relaxation of the tendon reflexes. Delayed relaxation of deep tendon reflexes. Delayed relaxation of deep tendon reflexes. So whenever we do a deep tendon reflex, the muscle contracts normally, but when it is relaxing, it stays contracted. It relaxes quite slowly. आपने आंखों के सामने देख सकते हो. Unfortunately, in this board, I cannot display a video, but if you go to YouTube and search for the delayed relaxation of reflexes, you will get the videos. Very classical. I will tell you a story also about it. Okay. And this delayed relaxation of reflexes, we have called it as Voltman sign. Voltman sign. See, I have already told you various named sign. तो पहला sign कौन सा था? Hartogge sign or Queen Anne sign, where the lateral 1/3 of the eyebrows are lost. Second is Hoffman syndrome, that is pseudo hypertrophy or fake bulky calf muscles. And then third, delayed relaxation of the tendon reflexes called as Voltman sign. So as you see in this picture, this child's calf look quite well developed, right? But they are not. They are not because of the muscle hypertrophy. This child has not done the calf raises with weights to develop that bulkiness. So this is nothing but what we call as Hoffman syndrome. This is pseudo hypertrophy. The calf muscles are edematous. So this is Hoffman syndrome. Okay. And the one that you are seeing here, they are trying to elicit the Achilles tendon reflex. Now when they elicit, the calf muscle contracts and then it gets released quickly. But here it contracts and it fails to release quickly. And we are going to call it as, we will call it as Voltman sign. Voltman sign, which is nothing but delayed relaxation of deep tendon reflexes. So when you do reflex, the muscle relaxes slow. It's all because of the myoedema. Okay. Now the second manifestation that I can get because of the hypothyroidism is proximal muscle weakness. Proximal muscle weakness. तो एक तरफ muscle edematous हो रहे हैं, दूसरे तरफ जो proximal muscles हैं they become weak because all the muscles to do contraction they need supply of glucose, blood, and they have to generate ATPs and use it. That process of generating ATPs is so slow that when you try to do activities, muscles are not getting the ATPs as much as they want, so they become dysfunctional or their ability to contract reduces, so we can have weakness. Larger the muscle, it needs more ATPs to contract. So जब disease में ATP production slow होगा, so larger muscles get affected first. And where do I find the larger muscles? In the proximal region, right? Around the shoulder joint we have large muscles, around the hip joint we have large muscles. So they present with what we call as proximal muscle weakness. They will have difficulty to comb, difficulty to climb, difficulty to get up from the sitting position. These are the classical presentation, right? So those are the musculoskeletal manifestations of hypothyroidism. So important points that I want you to remember is that all these are not important when you become a clinician, but they are important for exam. What I want you to remember as a clinician is that whoever comes to you with weight gain and fatigue, first thing you should think of, apart from the lifestyle, is that endocrine diseases. And among the endocrine diseases, hypothyroidism ranks first. Okay, I told you I will tell you a story of this delayed relaxation of reflex or Voltman sign, right? So when I completed my PG and started the practice, early phase of the practice, मुझे लगता था कि I have studied medicine very well and I don't miss a disease. Of course, it was my overconfidence. So once I got a patient who presented with some fatigue. He had this classical calf muscle hypertrophy, but which I overlooked. हाँ होगा शायद, walk करता होगा या exercise करता होगा, and he is bulky. But he was complaining of weakness, difficulty to get up, difficulty to comb, all this classical. So I was primarily looking at other causes for muscle dysfunction, including the inherited muscle disorders. I did all my evaluation and I found nothing. Like मेरे लिए तो diagnosis नहीं हो रहा था. I was not able to diagnose. Then I referred to a neurologist. Neurologist called me. The neurologist is where from the same medical college where I had studied, so I had a good respect for him. So that's why I referred to him, hoping that he will be able to diagnose. हमने बहुत कुछ किया था यहाँ पे. हमने muscle biopsy भी किया था, thinking that some storage disorders and all could be the reason. Nothing was conclusive. So neurologist immediately called. Patients called me saying that sir, we are going to the neurologist from this OPD की हम बाहर अब वेट कर रहे थे सर, अंदर सर बुला रहे हैं, जा रहे हैं, कुछ बात है तो आपको कॉल करेंगे. So patient called and told that sir, I'm getting into the OPD and if sir wants to talk to you, I'll call. Within 2 minutes I get a call, and this time the call did not come from the patient, from the neurologist, and he said, what is this Santhosh? How can you miss this case? This is classical hypothyroidism and I didn't expect this from you. How can you miss hypothyroidism? I'm like, sir, how did you pick up? Because his complaints were vague. Weakness, weakness, weakness. And he's like, I just tried to elicit the deep tendon reflexes and there was such a delayed reflex. And he made a video call, showed me his Achilles reflex, calf muscles contracted, not relaxing at all for few seconds. Straightforward. Now I know why did I miss, because when we think of hypothyroidism, which gender we think of when we think of hypothyroidism? The most common cause is Hashimoto's thyroiditis, right? Hashimoto's thyroiditis, we have to remember a few extra points. This is more common in females than males, with a ratio of 6 to 8 is to 1. With a ratio of 6 to 8 is to 1. मतलब 6 से 8 फीमेल पेशेंट्स होंगे हाइपोथायरॉयडिज्म के, तो एक मेल पेशेंट हो सकता है. एंड द पर्सन आई हैड वाज अ मेल पेशेंट. So my brain was conditioned to think of hypothyroidism in only females, and this was male, and that's why hypothyroidism did not come in my differential diagnosis at all. I was thinking of so many other conditions and I ended up missing it. But if I'd kept my mind open and had logically thought, I should have diagnosed it for the first time when he came to me. Happens, it's all the process of learning. Okay, just because I'm talking about hypothyroidism, few extra points before we go forward. Hashimoto's is an autoimmune disease, where autoimmune diseases as such are more common in females than males, and here autoimmune disease is because of antibodies, and the most common antibody that we get in these patients is anti-thyroid peroxidase antibody, TPO antibody, which is seen in more than 90% of the patients. More than 90% of the patients. So in a clinically oriented MCQs, whenever they mention anti-TPO antibody is positive, examiner is trying to push you towards the diagnosis of Hashimoto's. Okay, so we have a fair idea about what clinical features to expect. So tapa, see, myxedema, that's what myxedema is, a name given to edema. Basically hai kya? Edema. Edema is there. Edema means what? Collection of fluid. Why fluid is getting collected in hypothyroidism? Because in hypothyroidism there is activation of the fibroblast, and this activation of the fibroblast का काम क्या है? To deposit the glycosaminoglycans and hyaluronic acid. इनका प्रोडक्शन करते हैं fibroblast. So they get stimulated by this high amount of TSH. So they produce lot of mucopolysaccharides, GAGs and hyaluronic acid. So they get deposited in tissues. जहाँ जहाँ पे भी वो deposit होंगे, particularly hyaluronic acid. Hyaluronic acid is a hygroscopic substance. तो जहाँ पे भी deposit है, it will bind a lot of water molecules, and wherever water molecules accumulate, that is what we call as edema. So there is tissue edema, muscle edema, right? So one of such edema is where in the skin region there is deposition of hyaluronic acid. We are holding water molecules because of that, and we end up with edema. I don't want to call it as just edema. I'm going to call it as mixed edema, which is non-pitting. Non-pitting का reason क्या है? Normal condition में क्या है? Let us say there is a space where there are water molecules accumulated. So when I compress it, as I compress it, these water molecules get displaced, creating a pit. But अब mixed edema में क्या होता है? The water molecules are there, but these water molecules are stored in the tissue because of the hyaluronic acid. Hyaluronic acid is holding them. So when I compress it, I will not be able to displace this hyaluronic acid molecules. Hyaluronic acid molecules will be bound to tissue. तो वहाँ से वो displace नहीं हो सकते हैं. तो अगर मैं compress करूँगा तो hyaluronic acid displace नहीं होगा. तो if hyaluronic acid cannot be displaced, the water molecules that are bound to hyaluronic acid, they will also not be displaced. So that is how I end up with what we call as non-pitting edema. I cannot displace it. Edema is there, देखने में पता चलेगा, but you cannot create a pit. And that's very important to learn, because cosmetics में हम fillers use कर रहे हैं ना. So there are a lot of actresses who are using these fillers. Imagine if hyaluronic acid could be displaced. अगर hyaluronic acid displaced हो सकता था, so in the face they have filled hyaluronic acid. If it can be displaced, then it can create pit. तो कोई भी film का scene सोच लो where heroine is sitting like this कुछ सोच के, and whenever he removes her hand, there will be impression of the hand created because hyaluronic acid displaced, water displaced, pits all around. So such molecule cannot be used as a cosmetic filler. Hyaluronic acid इसीलिए choose किया है because once it is deposited in the tissue, it is not displaced. Slowly it gets degraded, but pressure cannot displace it. That's why it is a perfect filler. Okay, clear? So cardiac tamponade same. जो hyaluronic acid and other gags that are getting deposited in various tissues, they also get deposited in the pericardial space. So in the pericardial space, like ये heart है, यहाँ पे pericardial space है. So in the pericardial space, fibroblast will deposit hyaluronic acid molecules. So once fibroblast deposit hyaluronic acid molecules, it will attract and hold water molecules. So that is how I end up with pericardial effusion. जैसे ही water molecules और accumulate होते जाएंगे pericardial space में pressure बढ़ता जाएगा, it will start compressing the heart, and when it compresses the heart, the right ventricle will get collapsed under this pressure. At that point of time we call it as cardiac tamponade. When the heart is compressed causing the collapse of the right ventricle, we call it as cardiac tamponade, which is a life threatening condition, because now the right ventricle is collapsed, so it cannot be filled. Once I cannot fill the blood to the right ventricle, see, blood to left ventricle comes from right side of the heart. Superior vena cava, inferior vena cava bring the blood from the body to right ventricle. From the right side it goes to lungs, gets oxygenated, and then comes to the left side. So if blood is not entering the right properly, left is also not going to get sufficient blood, so cardiac output will come down even further, and that can result in hypotension and increased risk of death. Okay, so these are all the clinical manifestations we can get in a patient of hypothyroidism. So once someone comes to me with these features, mostly they are going to come to me with weight gain and fatigue, and as part of evaluation I do the thyroid function test. Now we'll see how to make a diagnosis. So once I do the thyroid function test, mainly we will look at the free T4 and TSH. These are two components of the thyroid function test. So when we do that, let us say in the first scenario, in all hypothyroidism, free T3, free T4 will be reduced. So free T4 is reduced, but the TSH appears elevated. In the second scenario, free T4 is reduced and the TSH appears to be decreased. So what does this indicate? जहाँ पे T4 कम है, the reason for T4 being low is not TSH being low. तो प्रॉब्लम कहाँ पे है? यहाँ पे थायराइड ग्लैंड के लेवल पे ही है. Thyroid gland is not able to work properly, so that's why I have decreased T3 T4, decreased T3 T4. But to compensate for that, to make the thyroid gland work more, TSH is going up, TRH will also go up. So in that case we will call it as primary hypothyroidism. Problem is in thyroid gland itself. Problem is in thyroid gland itself. And let us say here TRH will also anyway be, if done, it will be elevated. So this indicates primary hypothyroidism. Now if the TRH is high but free T3 and TSH are low, तो प्रॉब्लम यहाँ पे कहाँ पे है? Pituitary gland is not able to produce sufficient TSH. That is why T4 is low. But to push the pituitary gland to produce more TSH, the hypothalamus is working more. So that means the problem यहाँ पे pituitary gland के level पे है. So we will call it as secondary hypothyroidism. Hypothyroidism. And third scenario where everything is low, free T4 is less. इसका reason क्या है? Because pituitary is not producing sufficient TSH. Pituitary, why is it not producing sufficient TSH? Because the hypothalamus is not producing sufficient TRH. Then in such cases the problem कहाँ पे है? Hypothalamus पे ही है. So we will call it as tertiary hypothyroidism. Tertiary hypothyroidism. So once I suspect hypothyroidism, I have to primarily ask for T3 and TSH. TRH we will only get it done when I am suspecting tertiary hypothyroidism. अगर इसका suspicion नहीं है, then I don't need the TRH. Mainly I need is free T3 and free T4 and TSH. Okay. So in case of primary hypothyroidism, right? Let us go through this flow chart where we will understand it better. So in case of primary hypothyroidism, problem कहाँ पे है? Thyroid gland के level पे है. So in case of primary, I will have decrease in T3 T4. So in the lab investigation we are concentrating in free T4, but because thyroid gland is not producing sufficient T3 T4, ये negative feedback कट जाएगा, so TSH will increase, negative feedback यहाँ पे भी कट जाएगा, so TRH will increase. So in primary we will have increase in TSH to make the pituitary gland work more, and there will be increase in TRH. But secondary में क्या होगा? Secondary में the main problem is the pituitary gland fails to produce sufficient TSH. So there will be decrease in the TSH. There will be less TSH. अगर TSH कम है तो there is less stimulus to the thyroid gland, so that is why we will have decreased free T4. Okay, but because TSH is less and free T4 is less, the negative feedback is cut to the hypothalamus, so TRH will increase. Negative feedback is cut to the pituitary also, but यहाँ पे ही तो problem है. So pituitary is not able to produce TSH, right? But hypothalamus can produce more TRH. So in secondary, I will have increase in the TRH. Now let us think of the tertiary. Tertiary में problem कहाँ पे? Hypothalamus. So hypothalamus is not able to produce sufficient TRH. So if I don't have sufficient TRH, there is inadequate stimulation of the pituitary, so I will not have sufficient TSH. If I don't have sufficient TSH, there is inadequate stimulation of the thyroid gland, so I will have inadequate T3, T4 as well. So in tertiary, all the three are decreased. Okay, and in case of secondary, only free T4 and TSH are decreased, and in case of primary, only the free T4 is decreased. The easiest way to remember the primary, secondary and tertiary is how many of these parameters are decreased. So in case of tertiary matlab 3, all the three are decreased. Secondary matlab 2, right? So 2 parameters are decreased, free T4 and TSH. And in case of primary matlab सिर्फ एक ही decrease है, क्या है? T3, T4. The TSH and TRH are increased. So that way you can remember it. Okay. So once I have done and I have come to the conclusion that it is primary, how will I take it further for the diagnosis? क्योंकि primary के लिए बहुत सारे causes है. Myxedema मतलब primary के लिए we have Hashimoto thyroiditis, iodine deficiency, post-surgical and all. So how will I take it to the diagnosis? How will I get to know that this is Hashimoto's only, this is iodine deficiency only? So practically more than 90% of your cases are going to be Hashimoto's only, right? So you should start thinking about other causes only when you are thinking that it is not Hashimoto's. And Hashimoto's ke liye, what is the important antibody that I need to do for the Hashimoto's? So once I diagnose it as primary hypothyroidism, once I diagnose it as primary hypothyroidism, all I have to see is if there is history of thyroid surgery or radio iodine therapy. If yes, then that is the cause. Thyroidectomy or radio iodine therapy is the cause, right? If no such history is there, then I have to go ahead and do anti-TPO antibodies. Anti-TPO antibodies. And अगर ये antibodies positive हैं, that is clearly Hashimoto's. That is clearly Hashimoto's thyroiditis. But if these antibodies are negative, it does not completely rule out Hashimoto's, but we also start thinking about other possible causes. Other possible causes. For that, we need more detailed evaluation. So approach kya hai? Any hypothyroidism, first thing we should do is take a good history. Whether there was any exposure to drugs causing hypothyroidism, whether patient has undergone thyroid surgery or radioiodine therapy. If yes, it is most likely iatrogenic. The treatment is the cause or surgery is the cause. But if no, then it is most likely Hashimoto's. Iodine deficiency and other causes are extremely rare today. So you should just get the anti-TPO antibody done. Positive nikal aaya hai, so you clearly know that it is Hashimoto's. Don't investigate further. You can start treatment. If anti-TPO comes negative, it could still be Hashimoto's or other possible causes like iodine deficiency or thyroid malignancy. In such cases, we do more further investigation. Bharat, we will discuss the thyroid storm when we go to the hyperthyroidism. Okay. So today we'll restrict to hypothyroidism. So once I have diagnosed and I know that I'm mostly dealing with Hashimoto's, how will I manage these patients? Because if I don't replace the thyroid hormone, all these problems are not going to get resolved, right? It will make the patient's life quite disastrous. Even if they are just gaining weight, they're becoming fatigued, it has a significant impact on the quality of their life, right? Imagine like you're a doctor and your OPDs are busy, your emergency rooms are busy, and you have hypothyroidism. Your reflexes are slow, your brain's activity is slow, your thought process is slow, you're gaining weight, you're becoming diabetic. Will you be able to do a good job as a doctor? No, right? Even for a housewife, it affects so much, right? It can, even a poorly controlled thyroid function can affect the interpersonal relationships because they are tired, lethargic, right, less active. The family members start labeling them as being lazy or काम चोर हैं, they're escaping from the work and all. But once you start the thyroid hormone replacement, the quality of life improves just like that. So recognition is important, and once we recognize, management is important. So when it comes to management, the treatment for the hypothyroidism is primarily going to be thyroid hormone replacement. Thyroid hormone replacement. The form of hormone that we use is levothyroxine. Levothyroxine. अब कितना देना है, कैसे देना है, and how do I monitor it? That is what we need to learn, right? So we are primarily using levothyroxine. Levothyroxine. Now, how much dose and for whom to start? So for that, let us write down an approach. Whenever we have hypothyroidism, so let us say I am dealing with primary hypothyroidism, or for that matter, any hypothyroidism. So once it is diagnosed as hypothyroidism, should I start giving the hormonal treatment for all the patients? Should I give thyroid hormone replacement for all the patients? Answer is no. Like, let us say that I have a person whose free T4 is slightly decreased and the TSH, the normal range varies from lab to lab, 0.5 to 5.5 micro international units per ml. ये normal range है TSH का. And this patient का, I am just giving you an example of a patient. इस patient का TSH निकल के आया है 7 micro international units per ml. तो ये clearly किस type of hypothyroidism हुआ? T4 is decreased, TSH is increased. That means we are dealing with primary hypothyroidism. ये primary हुआ, right? Should I start the treatment for this patient? So Tapa Samantha, no. 500 mg we go for when we have Myxedema coma, right? Hypothyroid emergency, not for all patients. Does this patient require treatment? The answer is no. So once we have hypothyroidism, the first thing I should know is whether it is symptomatic or asymptomatic. जो भी सिम्टोमैटिक है उनको तो ट्रीट करना ही पड़ेगा, राइट? देयर होल मेटाबॉलिज्म इज गेटिंग अफेक्टेड, सो दे नीड टू बी ट्रीटेड. सो देन वी विल स्टार्ट levothyroxine therapy. The dose is going to be 1.6 micrograms per kg daily, once on empty stomach, right? Ideally like at least 1 to 1.5 hours before the first meal. So if they are having their breakfast after 8, ask them to take it before 7, right? On empty stomach. So this is very important. So when we are starting, the ideal starting dose is 1.6 micrograms per kg. So let us say that I am dealing with a 50 kg person. 1.6 microgram for a 50 kg person will be 50 into 1.6. That comes around 82 point odd. Okay, my maths may not be good. Somewhere around 80 or 82 point odd. So in India, we have the availability of 75 and 82.5. So I can start with 82.5. If it is not available, we can start with 75 micrograms. That is the starting dose. Okay. Now here, once I start, is that going to be sufficient for all the patients? Is that going to be sufficient for all the patients? The answer is no. The patient may require more. Then how will I get to know whether I am giving sufficient dose or not? So for that, I need to check the TSH after I start. When should I check the TSH? I should check the TSH 10 weeks later. So once I start 6 to 10 weeks, European guidelines recommend 10 weeks, so I'm writing it down as 10 weeks. 6 to 10 weeks later, you check their TSH. Now, if the TSH is in the normal range, if it is in the normal range, then it means the thyroid function is well controlled. If the TSH is in the normal range. But if TSH comes out as still high, or if it comes out as still, or if it has become low, below normal range. If it is normal, that means you have achieved the perfect dose. You will continue same dose. You will continue same dose. Whatever I had started, right? 50 kg, I would have started 82.5, and if the TSH has now come to normal, I will continue with 82.5. And once a good control is achieved, we will repeat the TSH not on a every 10-week basis. Once we have good control, we will check every 2 to 3 years. We don't have to do it on a monthly basis or every 3 months or every 6 months. Till you achieve the control, we need to keep titrating. We need to keep checking. So if it is 10 weeks later, if it is high, then what I should do? If it is high, TSH is still high, means it is not well controlled. I have to increase by 12.5 to 25 micrograms per kg. Sorry, 12 to 25 micrograms per day. Means let us say that I had started with 82.5 and it is not well controlled now. The TSH is still high. So I will add 12.5 or 25. Let us say I add 25, and whatever the sum comes, that will be the new dose for the patients. Once I do the new dose, again I will repeat the TSH after 10 weeks. So we will run the 10-week cycle till I get the TSH coming under normal range. Once it is in the normal range, that means our hypothyroidism is controlled. And if it is low, means TSH has gone low. When it will go low? When T4 is causing negative feedback and causing the suppression of TSH. More than required dose of T4 is being given. So in such cases, we have to decrease by 12.5 to 25 micrograms per day. So that is going to be our approach. So the starting dose होगा 1.6 micrograms per kg. थोड़ा सा ऊपर नीचे चलेगा because whatever nearest available commercially available dose जो भी है, we will start that. Once I start, 10 weeks later, I will repeat the TSH. TSH मेरा target क्या है? Normal range में होना चाहिए. Normal range में है, तो I will continue same. And then once in 2 years, I will keep asking the patient to come back for the follow-up with TSH. But if it is not in the normal range, that means I still need to titrate the dose. अगर high है, अभी भी high है, then I will increase the dose by 12 to 25. And if it is low now, below normal range, then I will decrease the dose by 12 to 25, and I will repeat the TSH 10 weeks later. So this cycle will continue, repeat TSH, adjustment of the dose till I get the TSH under normal range. Once it is in the normal range, I know that is the dose that this patient requires. That is the dose that this patient requires. Ranjan Bharti, yes. Unfortunately, Hashimoto's thyroiditis leads to significant destruction of the thyroid cells, and it is not completely recoverable. So once you have an established Hashimoto's thyroiditis, you would require the thyroid hormone replacement lifelong. The dose required may vary based on your body weight. Like if I gain weight, I might require more dose. If I lose weight, I may require less dose, but you will have to be on the drugs. And in fact, I can give you an example. Sudhapa was also asking me what is Myxedema. So I had a patient who was hypothyroid and she was requiring unusually high doses of thyroid hormone replacement. And she always had this concern that why am I requiring 250 micrograms per day when all other hypothyroid patients are only taking 75 and all. As usual, protocol ke hisab se we had started at 1.6, not controlled, TSH was high, so we kept on escalating. At 250 micrograms, we were able to control. We found out the reason for the unusually high dose requirement was that there were issues with the thyroid hormone absorption. So she had some chronic gut issues. She had an inflammatory bowel disease, Crohn's disease, so she had absorption issues, and because of that she was requiring higher amounts. जब हम 250 दे रहे हैं तब उनके शरीर को शायद नॉर्मल जितना चाहिए उतना मिल रहा था, रेस्ट ऑफ देम इज नॉट अब्जॉर्ब्ड, बट शी वाज नॉट हैप्पी. She was like, sir, why should I take 250? So there must be a solution. And she ended up with an alternate medicine practitioner or a quack who told stop all the thyroid medications. So she stopped all the thyroid medications. And a few weeks later, she came and told that I'm feeling good now that I'm off medication, which was a placebo effect or a mental self-reassurance that all is well. But then a few months later, she ended up with Myxedema coma. Myxedema coma is a condition where there is severe reduction of the brain's function resulting in coma. At the same time, it's not just the brain, because when your thyroid hormone level is so low, all other systems are affected. You will have profound bradycardia, heart rate comes down pretty badly. And when heart rate comes down, cardiac output comes down. So blood supply to the other tissues comes down. Your BP comes down crashing. So you end up with hypotension, severe bradycardia, and decreased brain function resulting in coma. Apart from that, so low BMR that even your body struggles to maintain the core body temperature. So you end up with hypothermia and hyponatremia. So all these features. So this happened because she stopped taking medications when her requirement was still there. So please make sure that when you diagnose someone with the Hashimoto's or the uncorrectable primary hypothyroidism, say iodine deficiency is a correctable condition. So where once you start giving them iodine, it gets normalized. But most common cause kya hai? Hashimoto's. No solution. So please ensure that your patients stick to medications and follow your advice regularly and not skip. Don't fall under this so-called, there are so many social media activists promoting this like thyroid medications are a scam, don't take, you can come out of thyroid disease and all. According to the scientific medical knowledge, that's not a possibility. Okay, so symptomatic hai to treat karna hi padega. We need to start levothyroxine. Okay, so one of the questions that appeared in recent INI-CET is that in what condition I should start lower dose. 1.6 is a standard dose, but in some conditions we should start lower dose. So start lower dose. What dose can be considered as lower? Generally, we will start regardless of the body weight. We start at 25 micrograms per kg. 25 micrograms per 25 micrograms not per kg per day. That's it. Regardless of the normally 1.6 start करेंगे तो 50 kg person will require at least 75 and 70 kg person will require 100 micrograms. That's the usual starting dose. But we are starting at 25 only regardless of the weight in certain conditions. If that's an MCQ that they can ask. The first thing is age more than 60 years. So अगर first time हम diagnose कर रहे हैं after 60 years, then don't start the full dose. Start 25 and then as usual 10 weeks later you check the TSH. TSH अभी भी high है तो increase by 12.5 to 25. You go on escalating till you reach the normal value. So therefore we start the levothyroxine on MC stomach because various components of the food interfere with the absorption of the levothyroxine. Okay. The second condition is in patients with ischemic heart disease. Ischemic heart disease. Both of them are believed to not tolerate the thyroid hormone replacement well because they would have been adjusted to the lower T3, T4 levels, their whole system, including the heart function and all. So when we suddenly try to give them the full normalized dose, they may not be able to tolerate. In fact, there is increased risk of developing atrial fibrillation. So for that reason, we start at lower doses for these two groups. We will give the dose that their body needs by adjusting according to the TSH, but we don't start with the full dose in the beginning itself. We slowly build it up. But for all other cases, standard 1.6. But then those who are asymptomatic, should I start the treatment? The answer is no. If they're asymptomatic, we call them as subclinical hypothyroidism. Subclinical hypothyroidism. Why is it called as subclinical? क्योंकि symptoms नहीं है. Hypothyroidism है but symptoms नहीं है, so we call it as subclinical hypothyroidism. Another important MCQ zone now is that in patients में, ideally speaking, we do not need to give them thyroid hormone replacement. But there are some subsets where we give thyroid hormone replacement even when they are subclinical. So subclinical, generally no need for the thyroid hormone replacement, or I will phrase it like this: levothyroxine replacement only in selective cases. Only in selective cases, मतलब सबके लिए ज़रूरत नहीं है. So what are the conditions where symptoms नहीं है तब भी हम thyroid hormone replacement start करेंगे? So indications for thyroid hormone replacement in subclinical hypothyroidism. Indications for treatment in subclinical hypothyroidism. So patient is not having cold intolerance or any of the classical symptoms of hypothyroidism, तब भी हम thyroid hormone replacement start करेंगे. First indication is planning for conception or as part of infertility treatment. Because having the even subclinical hypothyroidism increases the chances of developing infertility. So all those married couples who want to have a child but they have either male partner or female partner have subclinical hypothyroidism, it is better to start the thyroid hormone replacement even if they don't have any other symptoms. Okay, the second condition is when there is obesity. There are no other symptoms of hypothyroidism. Patient is obese. It may be lifestyle disorder like eating too much of food, junk and all would have caused. There are no other hypothyroid related symptoms. तब भी when we replace the thyroid hormone, metabolic rate increase होगा and it is better or easier for them to come out of obesity. Okay. Then third condition where replacement is indicated even in subclinical hypothyroidism is where TSH value is more than 10 micro international units per ml. Normal range क्या है? Varies from lab to lab. Rough range is 0.5 to 5.5 micro international units per ml. So if it is more than 10, even if they are not planning for conception, obesity is not an issue, no other symptoms of hypothyroidism, तब भी हम start करेंगे. Why? Because when it is more than TSH, TSH is more than 10, eventually like within few months they will end up with symptoms. तो क्यों wait करना है symptoms आने के लिए? We'll start the treatment, right? That is the third condition. So these are the indications for starting the thyroid hormone replacement in subclinical hypothyroidism. Overt clinical hypothyroidism जहाँ पे symptoms हैं तो सारे symptomatic patients को treatment start करना है. The standard dose is 1.6 microgram per kg once daily on empty stomach. Various drugs and food items influence or reduce the absorption of thyroid hormone and that's why we should give it on the empty stomach. And once we start the medications, 10 weeks later we check the TSH. मुझे TSH चाहिए normal range में जो है 0.5 to 5.5. If I start and the TSH has come to normal range, I will continue the same dose. अगर इससे ऊपर है, then I will increase the dose. इससे नीचे है तो I will decrease the dose. I will keep titrating the dose at intervals of 12.5 to 25 micrograms. Every time increase करना है तो 12.5 to 25, decrease करना है तो 12.5 to 25. And then repeat TSH 10 weeks के बाद होगा. Once I hit the TSH in the normal range, that is the dose for the patient. Once we have controlled TSH in the normal range, then we don't have to regularly monitor. Once in 2 years is also enough. In between, if patient loses weight, gains weight or develops any symptoms, we can check the TSH. Sutapa. See, hyper we will discuss as a separate topic. There's a lot of different causes for hyperthyroidism. तो वहाँ पे भी वो cause पे depend करेगा. Hyperthyroidism is most common cause is Graves' disease, right? In Graves' disease, the anti-thyroid medication that we use, they are not safe for long-term or lifelong use. So what we do in Graves' disease is we start anti-thyroid medications and we generally wait for 12 to 18 months. If the hyperthyroidism is reversed with the medications, then good enough. If not, we have to go for either radioiodine therapy or the thyroid surgery. We don't use anti-thyroid drugs for lifelong in hyperthyroidism. But hypothyroidism, what we are giving? We are giving the normal hormone itself. We are not giving any toxic drug. So we are just replacing what is missing in the patient. Patient is missing T3, T4. We are giving it. That's it. So it is quite safe, absolutely safe. There are no side effects as long as the dose is appropriately managed for the patient, where the TSH is kept within normal range. There are no side effects, absolutely zero side effects. Not taking the medications can put you at the risk of death, but taking the medications, absolutely zero side effects. So please recommend and do not discourage anyone who is hypothyroid saying that 12.5 ही ले रहे हो, 25 ही ले रहे हो, छोड़ दो चलेगा. Absolutely no, it has long term consequences. Okay, see Abhishek Singh, what matters here is the free T4, because the total T4 gets influenced by the levels of other substances to which the T4 can be bound, like albumin, thyroglobulin, उनके levels कम होंगे, then the total bound जो form है T4, that will be less. So your total T4 can be less in that case. So that's why we don't go for total. Total is influenced by your albumin levels, influenced by thyroglobulin levels, influenced by transthyretin levels. So it's not a reliable tool. That's why we are concentrating on free T4. So if your total T4 alone is low, but as long as your TSH and free T4 are normal, you are having normal thyroid functions. So the dose किसी के लिए भी standard 82.5 ऐसा नहीं है. Dose is based on patient's weight. Weight अगर 50 kg है तो 1.6 microgram per kg. Like let us say the weight is 100 kg. So for a 100 kg person, I have to multiply it with 1.6, so that becomes 160 micrograms per kg. So that will be my starting dose, right? So if it is a 50 kg person, half of it will be like 80. Now in India we have 82.5 micrograms available, so that's what I start. If the person is, let us say 70 kg, 70 into 1.6, roughly, I'm not exactly sure, roughly it comes around 100, so we start with 100. So starting dose is based on patient's weight. Okay. So I hope we have a little bit of clarity on the diagnosis and management of hypothyroidism. Okay, so now last bit we will learn before we wind up today is myxedema coma. It's one of the complications or a manifestation of severe hypothyroidism. We are going to call it as myxedema coma. Myxedema coma. It's a form of severe hypothyroidism. It's a medical emergency and it's a form of severe hypothyroidism. Now what clinical features I will get in this? So यहाँ पे T3 T4 production is so low that the patient ends up developing critical clinical features. What are those? When T3 T4 is very low, basal metabolic rate is so low that body is not able to maintain the normal body temperature. जो heat production के लिए चाहिए उतना metabolic rate नहीं है, so they end up with hypothermia. Okay. Second, they can develop hyponatremia. So please remember, hypothyroidism is also known to cause hyponatremia, and severe, of course, they will have hyponatremia. Okay. Then they will have hypotension. Why hypotension? Because our sympathetic activity plays an important role in regulating BP, because sympathetic activity causes vasoconstriction, elevates BP, right? Lower the thyroid hormone, lower is the sympathetic receptors, lower is going to be our sympathetic activity. So vasodilatation and hypotension. Okay. Then fourth manifestation here we can get is, now neurons also will not be able to work properly because of very low basal metabolic rate, very low availability of glucose, oxygen and ATP to the tissues. So we end up with coma. So hypothermia, hyponatremia, hypotension, coma, and we may as well get cardiac tamponade. Need not always be. So these manifestations can happen in a patient where there is severe hypothyroidism. Usually, why this severe hypothyroidism develops? It is usually due to poor compliance to medications. तो मैंने आपको एक story बताया ना, that patient she stopped because she started believing in alternate medication, alternate medicine. That is the most common reason. Okay. The another condition can be development of infections. So whenever we have infection, metabolic rate is supposed to increase so that tissues are equipped to fight with the infection, that increase energy expenditure, they're able to do that. But agar infection hai and I cannot boost the metabolic rate because of thyroid dysfunction, it can worsen the condition. So poor compliance to medication or infections can precipitate the thyroid emergency. That emergency we call it as myxedema coma, where patients present with hypothermia, hyponatremia, hypotension, coma, and may have cardiac tamponade. Okay, so now how do I treat these patients? How do I treat these patients? So the management of the myxedema coma. Here I need to quickly elevate the thyroid hormone levels in the patient, right? So how can I elevate? So that can be done by giving IV injection of levothyroxine. IV levothyroxine 500 micrograms. So this will give the necessary thyroid hormone, metabolic rate increase होगा, body heat, body temperature will start rising, hypothermia से हम थोड़ा बहुत deal कर सकते हैं, right? Increased metabolic rate can help your neurons to get activated, so brain function we can recover, right? And then sympathetic activity increase होगा, hypotension we can recover. So we give 500 micrograms of IV levothyroxine, and then once the patient is stabilized, we can give 100 micrograms per day, and according to the patient's thyroid functions we can titrate and titrate. Like once we have future TSH, we can titrate accordingly. But levothyroxine alone will not be enough. We need to give IV fluids, and the fluids that we choose here is not going to be normal or hypotonic saline, because these patients generally have hyponatremia. So we will give hypertonic saline. We will give hypertonic saline because these patients have low sodium. I will give high amount of sodium in the fluids, like 3% sodium chloride. Okay. And third, we might have to consider active rewarming, because they have hypothermia. They may die just because of hypothermia. So we need to rewarm them. Thyroid hormone तो हम दे रहे हैं, body will start generating heat, but it will take its time. Before that he may die because of the hypothermia. So we need to follow active rewarming. We need to give them hypertonic saline and IV levothyroxine. This is how we are going to manage a myxedema coma. So there are mainly three principles. So thyroid hormone दे रहे हैं, it is not going to be oral. I need to give IV because I am dealing with an emergency. Second, it will start working, but it's an emergency. So by the time it starts working, I may already lose the patient. So for that, I need to give them fluids to elevate their blood pressure, and the fluid we generally choose is hypertonic saline, but definitely not hypotonic fluids. And we might have to consider active rewarming, where we can instill warm fluid even into the patient's rectum to increase their core temperature, right? So that's how we manage the myxedema coma. So that completes our discussion of hypothyroidism. Please try to solve the MCQs on the app based on what we have, like on the topic that we have discussed. In the next class, we will start discussing the hyperthyroidism and thyrotoxicosis. So some of the hyperthyroidism related doubts I have not taken up because it will become quite clear when you go through that lecture as well. Okay. Okay, so Tapas Samantha, see, when we produce the thyroid hormone, right, T3, T4, that hormone is produced, not all of that is available in free form. Means less than 1% of that is in free form. It is not bound to anything. Remaining 99% is bound to albumin. Majority of it is bound to albumin. It is also bound to thyroglobulin, thyroid binding globulin, or TBG, thyroid binding globulin, TBG, and transthyretin. So these are thyroid binding proteins. So 99% is bound, 1% is free. But what is biologically active? It is the free form. तो काम कौन कर रहा है? जो फ्री है, right? जिनको हम बंदी बना के रखे हैं, they are not working. Among them, the one that is bound to albumin is able to release quickly and become free. जब भी ज़रूरत है तो कहाँ से आता है हमको? ये सब यूज़ हो गया, all that is used, and body still needs, then it comes from the one that is bound to albumin. So that's why the T3 T4 bound to free plus albumin bound T3 T4, this is collectively called as bioavailable thyroid hormone, because free ऑलरेडी काम कर रहा है, काम के लिए वो अवेलेबल है, एंड अल्बुमिन बाउंड इज इजीली रिलीज, क्विकली रिलीज, सो दैट इज ऑल्सो अवेलेबल फॉर मी जब भी शरीर को जरूरत है, इट्स क्विकली अवेलेबल. But these ones, the one that is bound to thyroid binding globulin and transthyretin is not readily available. It will become available only under extreme conditions where there is severe deficiency of thyroid hormone. Okay, so now functionally क्या matter करता है? Free form, right? This bound form का जो total quantity है, if albumin level decreases, so the amount of thyroid hormone bound to albumin will also decrease. So then the total is all this, every form put together, that is free plus bound form put together makes up total. Okay, and bound form is to these things. So जब albumin कम होगा, so the amount of albumin कम है, तो albumin bound thyroid hormone will also be less. तो वहाँ पे total का value less निकल के आएगा. But it has no major physiological consequences, क्योंकि जब तक जो काम करने वाला है वो नॉर्मल रेंज में है, ठीक है. एंड दैट्स वाई दिस एग्जांपल दैट ही गेव, फ्री फॉर्म इज नॉर्मल, सो थायराइड हार्मोन का काम चल रहा है. जब काम चल रहा है तो टीएसएच को ज़्यादा होने की ज़रूरत नहीं है, दैट्स वाई टीएसएच इज इन द नॉर्मल रेंज. ओके, सो इफ एल्बुमिन इज नॉट द रीजन फॉर टोटल T4 टू बी लो, देन इट कुड बी लो TBG और लो ट्रांसथायरेटिन. Commonly speaking, total T4 can go low most commonly because when it is not the hypothyroidism, then it could be because of albumin deficiency. अगर albumin low है तो it could be the other causes. But practically speaking, as long as your free T4 is fair and your TSH is normal, see, the best way to assess whether you have real hypothyroidism is when TSH goes up. If TSH starts going up, that means your thyroid hormone action is not sufficient. That is why pituitary is releasing more TSH. If that is not happening, TSH is normal, then you can ignore this total T4 value. And that's why this can be like a farce, in the sense you just get the total T4 done in a patient who is having low albumin, low TBG or low transthyretin, then total T4 will come low and you will think, oh, it is hypothyroidism, and start treatment, right? So don't do that mistake, go for free T4. So in practice, many times what happens is when you write thyroid function test or TFT, the lab may give the report of total T4, total T3, not just the free and bound, and that can be misleading. So whenever you get conflicting picture, जैसे कि TSH normal आ रहा है लेकिन total T4 या total T3 कम आ रहा है, so think of these possibilities, ask for a free T4 and then check. If free T4 also comes low, then you have to start thinking about it. But if free T4 is normal, then probably patient doesn't have hypothyroidism. Okay, so that's it from me today. So I'll see you in the next class. In the next class, we will discuss the hyperthyroidism and thyrotoxicosis. I will leave you with a small homework. So when we start the next class, I want you to tell me what is the difference between hyperthyroidism and thyrotoxicosis. These are two words that you come across. Hyperthyroidism और दूसरा word है thyrotoxicosis. Are they both same or different? Same है तो कुछ बात नहीं, अगर different है तो what is the difference between the two, right? Okay, so that's it from me today. I'll see you in the next class. Till then, have a good time, study well, see you, bye bye.